Hello, my name is Martin Gulliford and I'm Professor of Public Health here at King's College London. I'm going to describe some research that we've done into the safety of reducing antibiotic prescribing for respiratory infections in primary care. This research was done by a team of us here at King's College London, together with general practitioner colleagues from the University of Southampton, the University of Bristol and the Health Centre in Bicester, Oxfordshire.
In recent years, we've become increasingly concerned that the widespread and sometimes unnecessary use of antibiotics may be leading to the development of antimicrobial drug resistance. In primary care, some 60% of antibiotics are prescribed for respiratory tract infections, including common colds, sore throat, cough, acute bronchitis, otitis media and sinusitis. These are usually self-limiting conditions. They're caused by viruses and do not respond to antibiotic treatment. Nevertheless, antibiotics continue to be widely prescribed, with prescriptions being issued at about 50% of consultations overall. One reason why GPs issue antibiotic prescriptions is that they may be concerned at the risk of infective complications, including pneumonia, peritonsillar abscess, mastoiditis, empyema, bacterial meningitis, intracranial abscess, and Lemierre's syndrome. Our study therefore asked, is it safe to reduce antibiotic prescribing for self-limiting respiratory tract infections in primary care? We set out to determine whether there is a higher incidence of complications at general practices that prescribe fewer antibiotics for these conditions. We conducted a cohort study in 610 general practices from throughout the UK. The registered population included 4.5 million people who were followed up from 2005 to 2014. For each general practice, we estimated the proportion of respiratory consultations with antibiotics prescribed, and we estimated the incidence of each infective complication, and we adjusted analyses for a number of covariates. This slide presents some of our main results. In the leftmost column, you can see that we've divided the general practices into fourths according to the level of antibiotic prescribing. The forest plot presents the risk of each infective complication relative to the lowest antibiotic prescribing category as reference. For intracranial abscess, meningitis, empyema and mastoiditis, there was no evidence that the incidence of these complications was associated with a level of antibiotic prescribing. However, for peritonsillar abscess and pneumonia, there was evidence that the incidence of these conditions decreased as the level of antibiotic prescribing increased. In order to understand the clinical implications of these findings, we estimated the impact on a general practice with a list size of 7,000 patients. If such a practice reduced the proportion of respiratory consultations with antibiotics prescribed by 10%, we estimate that it may observe approximately one more case of pneumonia per year and approximately one more case of peritonsillar abscess per decade. Importantly, there was no evidence that mastoiditis, empyema, meningitis, intracranial abscess or Lemierre's syndrome would be more frequent as the level of antibiotic prescribing was reduced. General practices that reduce their level of antibiotic prescribing may experience a slight increase in the rates of pneumonia or peritonsillar abscess compared to high prescribing practices. However, there will only be a very small increase in the number of cases observed, and both these complications can be readily treated once identified. Reducing antibiotic prescribing could result in lower risks of antibiotic resistance, less side effects from antibiotic treatment, and less medicalisation of largely self-limiting illnesses.